can be subdivided into metabolic alkalosis and in acid-base disorder. We continued as per this at the metabolic alkalosis, respiratory alkalosis, and complex acid-base disorders are any combination of primary acid-base disorder excepting respiratory acidosis and respiratory alkalosis. Because this respiratory acidosis and respiratory alkalosis cannot occur in an individual at any moment or at any time, because a person cannot hyper and hypoventilate at the same time. Is it clear? It is not possible to do hyperventilation, hypoventilation at same time. Okay. We discussed up to metabolic acidosis. In metabolic acidosis, the primary characteristics is primary defect of metabolic acidosis is decreased bicarbonate concentration that ultimately leads to decrease of pH. And in respiratory acidosis, there is decrease of primary defect is decreased carbon dioxide tension, which also lead to decrease of pH. Okay. The variation between metabolic acidosis and respiratory acidosis is whether the bicarbonate is decreasing or carbon dioxide tension is increasing. In both conditions, if the bicarbonate decreases and carbon dioxide tension increases, the pH will decrease, and decrease of pH less than 3.5 can be termed as acidosis. Okay. And up to this is primary event, and we also discussed the causes of metabolic acidosis. That is not necessary to discuss again. And we have not discussed anion gap. Anion gap will be discussed after finishing this acid-base disorders. Okay. Compensation correction is that the two terms that make some student puzzled in the exam. Compensation means restoration of the ratio. Restoration of the ratio. Here in metabolic acidosis, this left hand figure, in metabolic acidosis, there is decrease of bicarbonate. Is it clear? And the decrease of bicarbonate concentration is responsible for decrease of the pH. Is it clear? And this decrease in pH can be restored to normal if carbon dioxide tension decreases proportionately. Okay. Is it clear? If decreases, then it is compensation. Then comes the question of the compensation, whether it is compensation is complete or incomplete. If it is complete, pH will be restored to normal. Okay. And the decrease of the bicarbonate and decrease of the carbon dioxide tension will be proportionate. Here we see this is when bicarbonate is decreased, and there is there occurs respiratory compensation. In respiratory compensation, increased carbon dioxide elimination that ultimately leads to decreased carbon dioxide tension. This figure, if we remove, we can wait. Someone is waiting. Okay. Okay. Now we are removing it for the time being. You see, is it clear? That ultimately can restore the pH. Is it clear? In next figure, you come the renal compensation and correction. We are again this in the biochemical finding of metabolic acidosis. You see, if it is uncompensated or not compensated properly, what happens? The proportion of bicarbonate and carbon monoxide tension not restored to normal. If their proportion is not restored to normal, pH will remain decreased. When their the proportion is decreased, is it clear? When they are decreased proportionately, then the pH will be restored to normal. Okay, this figure. Okay, if the decrease is so long it is not proportionate, so long the ratio 20:1 not maintained, in that case the pH will remain decreased. When the ratio is restored, then ratio will be restored. That means 20:1, the pH will come to normal. Okay. And correction means so long we are talking about compensation. Compensation means restoration of the ratio. Restoration of the ratio. If the ratio is restored, pH can return to normal, and returning of the pH to normal is very vital, because body cannot tolerate this variation of pH. And body is always dependent on cell function, is always dependent on normal pH. And correction, now condition the term correction. Correction means restoration of ratio as well as concentration. When the ratio and concentration is restored to normal and pH returned to normal, that can be termed as correction. Correct? Is it clear? Is it clear? It should be clear. Respiratory acidosis we discussed, and common causes of respiratory acidosis are bronchopneumonia, pneumothorax, pulmonary fibrosis, obstructive lung disease, laryngeal edema, even depression of the respiratory center. These are the probable causes of respiratory acidosis. In respiratory acidosis is characterized by increased carbon dioxide tension. If carbon dioxide tension is increased, you see, then the pH will decrease. Is it clear? This bicarbonate is the nominator, and the carbon dioxide tension, that is denominator. If the denominator is increased, if the denominator is increased, pH will be decreased. Previously in metabolic acidosis we have shown, if the bicarbonate concentration decreases, pH decreases. Here decrease of here decrease of pH is due to increase of carbon dioxide tension. Is it clear? Increase. And why carbon dioxide tension will be increased? In all these conditions, you see the bronchopneumonia, pneumonia, pulmonary fibrosis, laryngeal edema, obstructive lung disease, the elimination of carbon dioxide is defective. If the elimination of the carbon dioxide is defective, that means the carbon dioxide is retained in the body. That will increase carbon dioxide tension, and this carbon dioxide tension, increased carbon dioxide tension, is responsible for decrease of pH, that is termed ultimately as respiratory acidosis. Okay. So compensation, here compensation is again the renal system comes to compensate and correct ultimately. In acidosis, naturally there is more protons, proton concentration is increased. What will happen? There will be more elimination of protons through the renal route, okay, through the kidney, and as well as the kidney will do two or three more important things. Number one, that is recovery. The recovery of the bicarbonate will be increased, and kidney will also generate more bicarbonate, and synthesis and secretion of ammonia. Is it clear? This ammonia can act as buffer in the renal tubules. Okay. In respiratory acidosis, what we mentioned, this figure we want to remove for this. Is there anybody? Yes. For the time it will be removed. You see, this is the scenario in pH, pK, bicarbonate, carbon dioxide tension. In respiratory acidosis, there was what we showed. We showed the primary defect of respiratory acidosis is increased carbon dioxide tension. Increased carbon dioxide tension. To restore the ratio to normal, this bicarbonate should have to be increased. How this increase can be possible? That is through the renal mechanisms. The kidney will come forward. How kidney can come? It can help. Kidney can help this by excreting more acids. That will lower the acidosis to some extent, and by increasing the recovery of bicarbonate and generation of bicarbonate, also synthesis and secretion of ammonia. Okay. If the ratio is not returned to normal, that is called uncompensated respiratory acidosis. If the ratio is returned to normal, this ratio we know the bicarbonate to carbon dioxide concentration ratio is 20:1. Normally it is 20:1. When it is restored to 20:2 normal, that is called compensated. Is it clear? When it is not restored to 20:1, that is called uncompensated. And in that, if it is uncompensated, pH will show decrease. pH will decrease. If we find that pH will be decreased, we can understand whether the respiratory acidosis compensated or uncompensated by just observing these three parameters. Carbon dioxide tension, if we measure bicarbonate concentration, and pH, measurement of pH. Here, if we find that bicarbonate concentration, if this is tension is more, and pH, if the pH is decreased, then we understand that this is This is uncompensated respiratory acidosis, and compensation will be complete when the ratio is returned to normal. When the ratio is returned, that means ratio of bicarbonate to carbon oxide tension 20:1. At that condition, pH will be normal 7.4. And we mentioned concentration after compensation is met. Next target is to restoration of concentration. Is it clear? Next target is concentration. Then the concentration ratio and pH return to normal in correction. When it is corrected, completely corrected, concentration ratio and pH return to normal. Okay. Next, our next target is metabolic alkalosis. Metabolic alkalosis, primary abnormality of metabolic alkalosis is characterized by increased bicarbonate concentration. This is the primary defect in metabolic alkalosis. Increased bicarbonate concentration. If the bicarbonate concentration is increased, naturally the pH will be more than normal. More than normal, that means more than 7.4. Is it clear? It will be more than 7.4. Alkalosis we define if the pH is more than 7.45. Normal pH range is 7.35 to 7.45, and average pH is average blood pH 7.4. Okay, if the pH is more due to increase of bicarbonate, that can be termed as metabolic alkalosis. This is the primary defect. It can happen in vomiting. If vomiting, nasogastric suction, nasogastric drainage, what happens? Acids are lost. If acid is lost, then the bicarbonate concentration will proportionately increase. And in another biochemical abnormality, metabolic alkalosis will be evident in hypokalemia. In hypokalemia, is it clear? Metabolic alkalosis, hypokalemia remains almost hand to hand. Respiratory acidosis and metabolic acidosis and hyperkalemia, it is hand to hand, and the metabolic alkalosis, hypokalemia is also hand to hand. Okay. Ingestion of alkalis. Ingestion of alkalis, this incidence has increased previously. When there was peptic ulcer, the patients used to come. They used to take sodium, and that is alkali. When they used more sodium, then there was chance of a metabolic alkalosis. Now this has been decreased. Aldosteronism, hyperaldosteronism, metabolic alkalosis can occur. Other causes, endocrine cause, Cushing syndrome. So these are the more or less the causes of metabolic alkalosis. pH increase due to increase of bicarbonate. Increase of bicarbonate. Is it clear? And compensation. Compensation of metabolic alkalosis. Body efforts respond. First, the body efforts try to respond fast because they are the fastest acting. Then respiratory compensation. Respiratory compensation, what will happen? Decreased uh, uh, decreased ventilation result in increased carbon dioxide tension. Okay, decreased if ventilation is decreased. Ventilation is decreased, carbon dioxide is retained. In that case, there will be increase of carbon dioxide tension. If carbon dioxide tension is increased, that means the ratio is in the same direction. In that case, what will happen? There will be ultimately body will try to restore the pH to normal. If it is complete, if this increase of carbon dioxide tension is complete, and this increase can also happen and this bicarbonate concentration decreases simultaneously, that can also help to some extent. Okay, compensation of metabolic alkalosis. You see, if this respiratory decreased carbon dioxide if there is ventilation is decreased, the carbon dioxide tension increases and pH can decrease. Is it clear? And this decrease we mentioned, it can also help by decreasing simultaneous bicarbonate concentration. Okay. Biochemical finding of metabolic alkalosis. Uncompensated. If it is uncompensated, the proportion not return to normal, and pH will show increased pH. When it is compensated, the pH will be returned to normal. Is it clear? pH return to normal. This is compensated, full compensation. Okay. And after restoration, after compensation is restored, correction will take place. It is clear. There will be correction. That means restoration of bicarbonate concentration, carbon dioxide tension, and pH, and both three parameters when normal, that is correction. And all these three bicarbonate, carbon dioxide tension, pH, when all these three return to normal, that is called correction. Okay. Next, come to the point, respiratory alkalosis. Last one. Primary abnormality of respiratory alkalosis is decreased carbon dioxide tension. Is decreased in the carbon dioxide tension is decreased, pH can go up, pH can be increased. How it can happen? It can happen if someone overventilates, and ventilation or overbreathing is possible in hysteria, that is called hysterical overbreathing. And it can also happen in another way, in mechanical overventilation. This can happen in operation theater, also in intensive care unit. If we enthusiastically overventilate a person, then respiratory alkalosis can ensue, and also in hypoxia. And if you this may happen. If someone if someone ascends to very high altitude within short time, the persons who live in the highlands and mountainous regions, they have experience of this, and also in occur in salicylate poisoning. Salicylate poisoning, there will be respiratory alkalosis, and it is characterized by decreased carbon dioxide tension. And in compensation, the bicarbonate would have to be decreased, and if the bicarbonate concentration is decreased, then the ratio can return to normal. Okay, it can return to normal. And when it is when it is completely restored, then it is called compensated respiratory alkalosis compensated. If it is not completely restored, uncompensated. And the correction in correction of respiratory alkalosis, the all three parameters excepting the pK, that means bicarbonate, carbon dioxide tension, and pH, will be normal. All three parameters, when we find normal, that means it has been corrected. Someone is trying to enter. Who is that? Okay. This is regarding respiratory alkalosis. Causes and respiratory alkalosis can be experienced in hills and it can be experienced mostly by the mountaineers or the people who live in the highlands. Okay. Okay. Next. Our next target we want to discuss, we discussed already 8. There is no more. Biochemical assessment of renal function test. Your percentage is being given, don't worry. And this is important to show. Glomerular function test, that means estimation of these parameters, serum markers, blood urea, blood creatinine, and creatinine clearance test, inulin clearance test, and protein in urine, microalbuminuria. These are the biochemical parameters of renal function. Okay. And tubular functions, some of the tubular functions we do, as for example, urine concentration, dilution, acidification test, and estimation of plasma electrolyte. This is important. Potassium level, estimation of blood pH, plasma bicarbonate level. This is also important in acid base in the assessment of biochemical assessment of renal functions. This can be done is also in acid base disorders. Okay, and this is important. This is very, very important for the exam. It is the difference between unmeasured anion and unmeasured cations. It can be calculated from difference between measured cation and measured anions. Okay, it is the difference between unmeasured anion and unmeasured cations. Okay, normal anion gap is 8 to 16 millimole per liter. The term anion gap is a misnomer. Why it is misnomer? We can understand here in this simple equation. This equation you see anions in this here, anions and cations. Wherever you go to the body, be it in extracellular fluid, be it intracellular fluid, anywhere, the anions are equal to cations. Cations are equal to anions. Among the anions, these anions can be divided into measured anions, unmeasured anions. Some anions can be measured, some cannot be measured. Same thing happens regarding cations, measured cations, unmeasured cations. These together constitute cations, total cations. If the equation is this, You see, unmeasured anion minus unmeasured cation will be equal to measured cation and minus measured anion. Is it clear? This, according to the definition, it is the difference between unmeasured anion and unmeasured cations. Now come to the question, measure what cations can be measured. The most important cation that can be measured is sodium. Sodium from extracellular fluid. And most important anion that can be measured in extracellular fluid is chloride and bicarbonate. Is it clear? You may be arguing that potassium is, yes, potassium is also cation that that its concentration is also measurable, but you think you consider the concentration of potassium is much less than concentration of sodium in the extracellular fluid. Potassium is mostly concentrated within cells. You know, potassium, most potassiums are within the cells, and most sodium is in the extracellular fluid. That's why potassium we can ignore. Or if you can, if you want to add, you can add, but its contribution will be very less, very insignificant. That's why potassium have not been shown. If you show here sodium plus potassium, it will not, this will not harm. Is it clear? This will not harm, but usually we can show that the measured cations are sodium minus chloride bicarbonate. Okay, and here for estimation of potassium, if we do, it can cost more money. Is it clear? The more the test, more money will be running from your pocket. Okay, so anion gap, you will understand, this definition is very important. It is the difference between unmeasured anion and unmeasured cation. It can be calculated from difference between measured cation and measured anions. Next, come to the point. Plasma anion gap represents plasma proteins, mostly albumin. It is decreased in hypoalbuminemia. Anion gap is used. This anion gap is very useful in the categorization of the metabolic acidosis. High anion gap metabolic acidosis and normal anion gap metabolic acidosis. High anion gap metabolic acidosis are lactic acidosis, ketoacidosis, renal failure. Is it clear? Normal anion gap metabolic acidosis can occur in diarrhea, renal tubular acidosis, RTA. So this is anion gap is estimation of anion gap is important for categorization of metabolic acidosis. Okay. And another anion gap is in biochemistry, that is urinary anion gap. Urinary anion gap is the difference between sum of urinary cations, sodium and potassium, and urinary chloride. Here potassium is considered. Why considered? Because more in urine, more potassium is passed than sodium. More potassium is passed than sodium. Sodium is considered by the body as gold. Most if the sodium, most of the sodiums are reabsorbed in the renal tubules. Okay, and potassium in distal tubule we know sodium reabsorption of sodium in exchange for potassium secretion, and that potassium secretion ultimately destined for potassium excretion. Is it clear? Body excretes potassium. Body excretes potassium, but in some conditions, when there is potassium deficiency in the body, in that case, potassium can also be reabsorbed, and in that case, potassium excretion will can decrease. So urinary anion gap, we know it is the difference between sum of urinary cations, sodium and potassium, minus urinary chloride. The most important anion that is passed in urine is chloride. Urinary anion gap is always negative. It ranges -20 to -50 millimole per liter. -20 to -50 millimole per liter. It is always negative. In metabolic acidosis, urinary anion gap increases. In respiratory acidosis, in renal tubular acidosis, anion gap moves towards positive. Is it clear? So, diarrhea and when the anion gap is normal, we can be confused whether it is due to diarrhea or due to renal tubular acidosis. If the anion gap if it moves towards positivity, that means if it is decreases from this ratio, normal level -20 to -50, if it moves to positivity, that means if it becomes say -10, -30, then we understand that this could be due to renal tubular acidosis. Is it